I'm Susan Bowers and I'm an independent prescriber. There's some debate about the tear film. It's generally assumed that the surface is composed of lipids which are secreted by the Meibomian gland. The next layer is the aqueous layer. At the bottom you have a mucin layer. Now classically we used to draw these as three separate layers, but now they think that the mucin layer and the aqueous layer are slightly intermixed. So you have your lipid layer on the surface to prevent evaporation, followed the aqueous layer, and at the bottom the mucin layer, but these two areas are overlapping. Patients who are dry have a lower amount of lactoferrin lipocalin, secretory IgA and lysozyme, and therefore they're at a higher risk of having eye infections. Patients are very confused when they have epiphora and their eyes water when they're cold and when they're windy. You have to explain to your patients that there are three sorts of lacrimation. There's the pain that they have when they get a piece of foreign body or grit in their eye, which makes their eye stream. There's the lacrimation they do when they're upset and their lacrimal contracts and they cry because they're upset. And then there's their normal tear secretion. If the normal tear secretion is so thin that the surface breaks up and the corneal nerves are exposed to air, then they trip into their foreign body reaction and their eyes will absolutely stream. And this happens more with exposure to the cold and the wind, which patients find very confusing because they're suffering from dry eye symptoms and yet they're crying. So I usually tell them it's like a pendulum. They get so dry that their eyes have to cry to wet themselves. In these days of computer use, people tend to get relatively dry eyes because they work in central heating and air conditioning. They also drive about 10,000 miles a year, which means that when they're driving along with the demister on the car windscreen, the air, the warm air, is bouncing right into their eyes. And so patients tend to get more and more dry, and this is becoming an increasingly problem area for practitioners. So knowing that using a computer is such a common problem, what I advise the computer patients to do is to get a brightly coloured piece of paper, write blink on it, and if they use spreadsheets, blue tack it to the bottom of the screen. And when they're going down their spreadsheet and they see the little, in this case, green piece of paper, they need to blink. And if they do word processing and they read sentences, I then advise them to put a brightly coloured sticker so that when they finish the sentence, they can blink before they go back to read another sentence. This hopefully will increase their blink rate from the low 6 times a minute back up to the roughly 14 times a minute that they should be blinking. If you look at some of the common drugs that patients will take, you'll be surprised how dry they make your eyes. If you use one of the hypertensive drugs, like atenolol, then one of the side effects is decreased lacrimation. In the hay fever season, if you go to the pharmacy and you buy an over-the-counter antihistamine and take a systemic antihistamine, you'll be surprised how dry that will make your eyes. The second most common side effect from taking an over-the-counter drug like Piriton is dry eyes. There are so many drugs that your patient can be taking that will make them dry, and in particular the one I find the most common is aspirin. Also, the things that you'll find that the patient might be taking which can cause them to be dry is HRT, the contraceptive pill, and also some of the tablets for depression. Let's try aspirin on this iMed Info database. Stevens-Johnson syndrome is the 4th most common side effect from taking aspirin. Stevens-Johnson syndrome is an autoimmune disease which occurs mainly in young children and teenagers, and it's quite a serious issue. This is normally treated by the ophthalmologist in the anterior segment clinic, and I think that probably should refer in any cases that you diagnose. If you leave Stevens-Johnson syndrome untreated, then you get quite a lot of scarring, and the use of cyclosporine can help to reduce this inflammatory effect. The eMedInfo database is incredibly useful when you want to go through the list of patients' drugs to find out if some of the systemic drugs make their eyes dry. You can go through the whole list of drugs that they're taking, and the database was developed by Professor John Lawrenson with David Thompson, and it's available from Thomson Software Solutions. A few years ago this was distributed by the College of Optometrists so that all optometrists got a copy for 12 months. How do you know that your patient needs to have a dry eye assessment? Well, during your examination, when you're doing a routine refraction, the patient may be using hypermelos from their GP, or the patient could give you some dry eye symptoms. One of the easiest ways to decide whether you should give the patient a full dry eye assessment is to use a dry eye questionnaire. And the McMonnies Dry Eye Syndrome questionnaire from Charles McMonnies at the University of New South Wales is incredibly useful. Now, you can actually score this if you want to do research, but if you just fill it in, you would find that you could tell whether the patient was dry-eyed or not. And at the end are some references to the work of Professor Charles McMonnies. If you wish to have a copy of the dry eye questionnaire so that you can use it with your patients, you will need to email Charles, and at the end will be the reference for his email address. As part of the reference, you'll find that the sensitivity and specificity is 92% and 93% by using this dry eye questionnaire. You can then decide whether you think the patient needs to have a full dry eye assessment. Today we have a patient for you to look at with me who suffers from quite dry eyes and has done for a number of years. She does suffer a little bit with arthritis, which causes hyposecretion, so her aqueous is deficient, and she also has some Meibomian gland dysfunction, which you're about to see, which means that the surface oil is not very good and the tears evaporate very fast, which causes her to have quite a lot of discomfort, and she needs to put drops in, and she also has punctum plugs. So now I'm going to look at patients' tear breakup time. Now there are several ways that you can measure tear breakup time. One is to do an invasive tear breakup time, and the problem with that is that you use fluorescein. If you put a lot of fluorescein in, then you'll find that the tear film will become unstable. And so there are special florets which are very tiny with a narrow neck to reduce the amount of fluorescein that you put in. I personally would prefer to do a non-invasive breakup time. Then I haven't got to worry about the amount of fluorescein, and also some patients that are very dry just will not fluoresce, and you end up having to put saline in to get any fluorescence, which obviously defeats the object of the test. So let's have a look at some non-invasive breakup times. A very old-fashioned method to look at the non-invasive breakup time would be to use a keratoscope and shine a grid pattern on the patient, and then you get the patient to blink and you watch until the Myers distort. You can do this on a keratometer, and what you need to do it is a stopwatch. So you can use a stopwatch, get the patient to blink once and stare as long as they can, and then when the Myers distort, you stop. So what you actually do is you get the keratometer Myers in focus and get the patient to blink once, and then you start your stopwatch, and then when the Myers distort, you stop it. If you put the patient onto the video keratoscope, you can get the little circular rings in sharp focus, and then you get the patient to blink once, and then you start your stopwatch, and then when the circles degrade, you know your tear film's breaking up, and you can stop the stopwatch and you've got your breakup time. What you've got on a modern keratoscope is you've got these Myers, and you can see them very clearly. And when the patient blinks, if you blink, you can see the surface and the oil flowing over the surface of the lens, of the cornea. So all you've got to do is blink once, okay, and then start the stopwatch. And then when you see those Myers distort, like now, they're going all grainy. Okay, that's 12 seconds. We measure the tear breakup time, and I prefer the non-invasive tear breakup time. Okay, so blink for me and stare as long as you possibly can and try not to blink. And what we're trying to do is to measure when those gratings, those mires, distort. There we go. Now the patient had to blink then because the tear film had broken. And then we look at the number of nanometers thick the lipid layer is, and I like to use a Tearscope. Tragically, Keeler don't make them anymore. I would like them to go back to making them. You might be able to buy a second-hand one. If you get the patient to blink, you can see the distribution of the lipid across the surface of the eye, and by referring to the chart you can work out how many nanometers thick your lipid layer is, and you can get all sorts of patterns on the surface. Okay, so blink gently for me to spread the lipid across the surface of your eye, and I want some nice slow blinks. Now on this particular patient you can see that that's a very grey surface, and so there's very little oil on the surface of the eye. So I'm pretty sure that this patient may have some problems with Meibomian gland dysfunction because the lipid layer is so thin. These patients have very thin lipid layers on their surface because you can see that there's almost no coloured reflection. This patient is slightly better, but you can see the coloured fringes. And so really the more rainbow pattern you get, the thicker the number of nanometers. In the patient that we saw earlier, that's probably somewhere between 15 and 50 nanometers thick lipid at the most, and I would suggest it's probably quite a low figure. When you've used a Tearscope and you look at the surface of the tear film, you can look at the lipid layer and you can tell what sort of pattern of lipid you're getting on the surface when the patient blinks. If the patient has a dark eye, then these are the patterns at the top here that you can see. If the patient has a light coloured iris, then you're going to get the patterns underneath. And if you have an open meshwork, which is the first picture, there's very little colour on the surface lipid, it's quite grey, and the thickness is probably 15 to 50 nanometers. If you go for a closed meshwork, then you're talking 30 to 50 nanometers. A wave pattern is 50 to 80, an amorphous pattern is 80 to 90, and then you're getting quite a lot of coloured fringes, sort of rainbow patterns, and so that's about as thick as you can get on a lipid layer. And it's unusual to get that amount of oil on the surface of the eye. So this is a very good way to look at your Meibomian gland dysfunction, because if your Meibomian glands aren't working correctly, then you're going to get some incredibly thin measurements, probably this open meshwork, which looks a sort of grey colour. So when you've got a typical wet patient, you'll find that they have quite a lot of coloured fringes on the surface of the lipid layer. And as the patient's eyes become drier with Meibomian gland dysfunction, you will lose these coloured fringes and lose the patterns, and so that in the end it's quite a grey appearance. When you treat the Meibomian gland dysfunction and the patient uses, say, the eye bag or the steam goggle, after 2 or 3 months you will notice a big improvement in the colour pattern fringes, and you can photograph this and show it to the patient, and you'll see that perhaps they will go from the open meshwork to a wave pattern in about 2 to 3 months. After 6 months of treatment, if you've opened as many Meibomian glands as you can, you might go onto an amorphous layer, and you've got lots of coloured fringes to show the patient on photography if you take pictures. When you have Meibomian gland dysfunction, you have a dropout in the Meibomian glands in the upper and lower eyelid. And in fact, you have more Meibomian glands in the lower eyelid and you lose more of those before you notice that you're dry-eyed. 16.9% loss in the upper eyelid and 28.7% loss in the lower eyelid will result in you feeling dry. This is the patient's lower eyelid inverted. Now the lower eyelid is thicker than the upper eyelid, so you have more Meibomian glands in it, and the nasal 1/3 contains the most number of Meibomian glands, and the temporal 1/3 contains the least number. 60% of your secretion from the lower eyelid comes from the nasal area. So this is the upper Meibomian gland, and that is more curved, it's thinner, and it has less Meibomian glands than the lower lid, and the fallout of Meibomian glands is generally more in the lower lid than the upper lid. In the lower eyelid, the meibum increases in viscosity and gets thicker and thicker, and then it will block the gland, and you can get these things called toothpaste secretions where the gland is plugged. This is the typical Meibomian gland dysfunction patient with the telangiectasis, and that's caused by the surface not being made waterproof by the Meibomian layer, the meibum, the oil from the Meibomian gland, and so the surface is damaged by the tears. This is the upper eyelid and the Meibomian glands, and this is filmed with infrared using the Meibomian gland analyzer that I've just shown you. This is what a normal Meibomian gland looks like, and this is an abnormal Meibomian gland. When you see telangiectasia on the patient's lower eyelid, it looks a little bit like varicose veins. This is caused when the lipid from the Meibomian oil in the gland, the meibum, isn't coating the lower eyelid surface and making it waterproof. So the surface is damaged by the tears. And when you see this giveaway telangiectasia, you know that it's connected to Meibomian gland dysfunction. Meibomian gland dysfunction tends to start with male patients in their late 20s, and some of the Meibomian glands will stop working. Women tend to get Meibomian gland dysfunction more in the 30s, and they tend to find that they're older when they get the same symptoms of dry eyes, evaporative tear dry eyes. As you get older, it's always the males who tend to have worse Meibomian gland dysfunction. So the women tend to have more aqueous deficiency postmenopausally. So you tend to find that if you take the typical 70 to 80-year-old, it's the males with the severe dry Meibomian gland dysfunction symptoms, and it's the ladies who have better Meibomian gland function but more aqueous deficiency. So what do you do about this? Well, you really need to heat the meibum so that it melts, and to get it to the right temperature it's quite a difficult thing to do. If you put the eye bag in the microwave for 30 seconds and you put the white silk side onto the eye, then it takes 5 minutes to reach the correct temperature to melt meibum. So you then need to keep it there another 5 minutes to help to make the meibum liquid and open the glands. So you actually need 10 minutes of treatment, 10 minutes in the morning and 10 minutes in the evening. Now, in order to improve the Meibomian glands, you need to do at least 2 months treatment for a mild case. And if the patient has had Meibomian gland dysfunction for years, after about 3 months, you can see that half the glands are open and half the glands are still blocked. At the end of 6 months treatment, then as many glands as can open will be open. And we mistakenly decided years ago when we first tried this treatment that in order to keep them open after all the hard work the patient had done, you only needed to use the Meibomian gland once a week. However, all the patients reblocked and the Meibomian oil became very viscous and plugged all the glands. So you actually need to use the eye bag for the Meibomian gland dysfunction for 10 minutes every other day in order to keep them from reblocking. And that's quite a big job for the patient. Put the eye bag in the microwave for 30 seconds and the silk side holds the heat and it's at a hotter temperature. So the black side is on the outside and it contains flax seeds. Now, can you close both eyes for me? And the patient needs to wear this for 10 minutes and that needs to happen for twice a day. This is so much better than wet flannels dripping or any other method. It's far more convenient for the patient. If you have a non-compliant patient who can't find the time, then you can also try the steam goggle from Spectrum Tear. So we've tried the eye bag and we've tried the Spectrum Tear steam goggle, and in the meantime, while these are working, you probably need to help the surface of the eye to have more lipid to stop the evaporation of the aqueous. And so we tend to use two treatments. First of all, you can use a liposomal spray. And there's a new study in Contact Lens and Anterior Eye in volume 35, and that shows that one of the liposomal sprays increases your tear breakup time substantially. But two of the liposomal sprays, because they have a different chemical synthesis of the lipid, actually destabilise the tear film and make things worse. You can add a drop which contains a chemical synthesis of the lipid and something like cysteine balance, and there may be various other companies making these teardrop replacements, and so they need to put that in 4 times a day, morning, lunchtime, tea time, bedtime, to try and increase the layer of lipid on the surface. But of course, as their treatment works, they won't need to do that anymore. One of the treatments which is widely used in America is Meibomian gland expression, where you apply pressure to the Meibomian glands to try and expel some of the contents of the oil. Now, the melting temperature of meibum increases when the cholesterol esters change, usually with hormonal change, and so the melting point of meibum is a higher temperature. This means that it takes longer for the eye bag to heat up to the correct temperature to melt meibum, and so they feel that expression of the Meibomian glands might help to restore normal function. There is a machine used in America which is a single-use machine, which is quite expensive, that you can put in and it will compress the Meibomian glands to try and express some of the oil. The treatment isn't available in this country yet, and it is quite an expensive process to do this. Now, the next problem that we have is if when we do the measurement, we find that the aqueous layer is deficient. So now I'm going to stain the patient with a combined stain of 1% fluorescein and Lissamine green. Never use 2% fluorescein on a dry-eyed patient because it just won't fluoresce and you'll have to add saline to see anything. So I'm just going to put in this combined stain. I'm just going to give you a tissue in case you want to blink. You can definitely see how dry this patient is by this green stain. She's staining beautifully with Lissamine green now, and also in the nasal area. And you can also see that she's fairly hyperemic as well. And of course, redness and dryness are linked, so the drier you go, the more hyperemic you become. And so a lot of the the computer users have pink eye by the end of the day if they've spent 12 hours on the computer, because their eyes are so dry in central heating or air conditioning and not blinking. If we go to blue, we can look at the corneal surface. So if you look at the surface of the cornea, normally with a dry-eyed patient, it's the lower 1/3 of the cornea which stains. And I've got some photographic examples to show you that. And you look at that bottom 1/3 quadrant here, and that's where you'll get punctate epithelia erosions if the patient is very dry. However, the conjunctiva is quite stained with a fluorescein, as well as with Lissamine green. The cornea itself, there is a small stain here. And 3 and 9 o'clock staining where the eyelid doesn't completely close is an interesting feature, seen mainly in contact lens patients actually, the old gas permeable wearers. But you can also get it with dry eye patients. But normally the staining is in the lower 1/3 area, and this patient's cornea isn't too bad at all compared to some patients. And I've got some photographs of that later to show you. So let's have a look at some typical dry staining when they're aqueous deficient. The staining is always in the lower 1/3 of the eye. I've got quite a lot of pictures of staining here, and you can see that that area is always the area that gets the punctate epithelial erosions. So this is a typical case of dry eye that we saw earlier, and this patient's conjunctiva is staining with Lissamine green. We always use a combined stain. This is the opposite side of the same eye. Now, this is a dry-eyed patient, but occasionally patients will tell you that their eyes itch. Now, in a hay fever season, how do you know if it's a dry eye itch or a hay fever itch? This is dry eye staining. This is hay fever staining. There's a big difference between these small, tiny little stains with Lissamine green and these larger areas with the conjunctival folds of dryness. I'm going to try this Phenol red thread to measure your aqueous production. Phenol red thread is now available in this country, and I believe it's Hilco that stock it, because we've had to order it from Denmark previously, but now we can get it locally. With Phenol red thread, you have a sterile yellow strip of cotton, and when it becomes wet with the tear film, it turns red. And the normal production in 15 seconds is 30 millimetres. This is quite comfortable for the patient. You don't get a foreign body tear reaction, which you do from using the old Schirmer test. So I'm just going to hook these sterile little strips over the patient's lower eyelid for 15 seconds, and we'll measure her tear production. It helps if you have a watch with a second hand. So just look up for me and keep nice and comfy. It'll only take 15 seconds. 5, 10, 15 seconds, and then you remove the Phenol red thread, and you can see that the strip has gone red because it's wet, and you can actually measure how many millimetres of aqueous in 15 seconds. Normal amount is 30. This patient's got probably 18. Then you measure the other eye. Looking at the tear meniscus in the nasal area, in the old textbooks it said that the height was 1 millimetre, but in 2006 the Aston team of researchers showed that when they measured it with photography and graticules, the normal height of the tear meniscus is actually 0.3 of a millimetre, and it's in volume 29 of Contact Lens and Anterior Eye. So at the end of this lecture there will be a reference to it. Some years ago we did a clinical trial and we had 12 little old ladies who were marginally rheumatoid arthritic and dry-eyed. Rheumatoid arthritis produces hyposecretion, so you don't produce as much aqueous. These ladies had to sign the protocol to put in the drops 4 times a day. Now previously they'd only put the drops in when they felt really dry and not really bothered and just sort of, put up with it. Every single person on that trial improved because their compliance went up to 4 times a day. So whatever drop you use, it's really important that you use it 4 times a day. The drop that they all found was particularly good was one that we tend to use, and there's an overnight gel and there's a non-preserved drop that you can use during the day, and it's called Theratears, and that's been particularly effective on some of the very dry patients. So the patient has to put drops in if they have aqueous deficiency, if they're not taking nutritional supplement and they don't have punctum plugs. Sometimes they actually need drops as well anyway. If they use their drops 4 times a day, which is what I would recommend, then they may have an allergy to the preservative. I recommend that if you have to put drops in 4 times a day or more, you go preservative free. This is a patient who is allergic to the benzalkonium chloride, BK, preservative in their eye drop. It's quite a noticeable effect. This is a patient who is allergic to preservative-free solution that contains hyaluronic acid. This took 3 weeks for this allergic response to happen on a preservative-free eye drop. If you want to have a look at papillary conjunctivitis, the end of the little tiny blood vessel dilates, and so you see a tiny red spot at the end of the papillary, and it looks a little bit like frog spawn actually, with little sort of red bits at the end. So if you have an aqueous deficient patient, and a lot of the rheumatoid arthritic patients do hyposecrete, so they do have aqueous deficiency, and also as you age you produce less aqueous anyway, you can try a nutritional therapy. If you have a deficient aqueous layer, then you have 2 choices really. First of all, it's very common in people who are zinc deficient. If you are vegetarian or vegan, you notice after 2 years of being vegetarian or vegan, generally your eyes get a lot drier. Or if you only eat chicken and fish and not red meat. And this tends to be zinc deficiency. And so patients need 15 milligrams of zinc a day according to the World Health Organization. I used to recommend a supplement which contained a multivitamin and multimineral with 15 milligrams of zinc, because you need vitamin B6, you need manganese, you need magnesium, you need traces of copper. Last time I lost count at 108 micronutrients that the tear film contains. And I used to send the patients with a shopping list to buy a multivitamin and multimineral and take omega-3. But now I found this tear supplement to make you produce tears with all the micronutrients in it. It's called Legat Lacrima, and you take 2 capsules a day and it contains the micronutrients to make tears. Now, if your patient takes that for a couple of months, hopefully their eyes will get a lot wetter. And particularly if they've got a combined problem where their tears are evaporating because the Meibomian layer is missing and they've got aqueous deficiency, which is quite a common problem. And if you find that they've taken the nutrient for 2 months and they still have aqueous deficiency, you can then put in some punctum plugs. The first thing you can do is to put in a collagen temporary plug, which will dissolve in a matter of a few days, to see whether the patient has any relief from their dry eye symptoms. If you want to put in the plugs, the first thing you need to do is apply an anaesthetic. You then dilate the puncture large enough to take the plug. With the old-fashioned plugs, you used to have to measure the size of the puncture to find out what size plug to order, but with the smart plugs, then they expand with body heat, so you don't need to worry about that. With the collagen plugs, they're in 3mm and 5mm, so that you can choose 2 different sizes, and the patient can tell you when you've applied them if it's successful and they feel better. You dilate the puncture and then you put in the plug when the puncture is large enough to take it, and push it well down, because the patient will get discomfort when the anaesthetic wears off if the puncture is proud, and you'll need to push it further down. I'm sure they'll be able to tell you later when the anaesthetic wears off if the puncture isn't pushed in enough. So I think if the patient's still taken their nutritional support for 2 months and you then find that they're still aqueous deficient, as well as treating the lipid layer, if it is defective, you might want to put some punctum plugs in. Some patients get a lot of relief from this. There is, however, a biofeedback system, which means that over a period of months, it's possible that they'll produce less aqueous if the drainage isn't particularly good. But certainly for about 18 months, the patients definitely notice an improvement. About 20% of your patients will have dry eye, and in that case they'll have a raised osmolarity. When you are giving the patients treatment because you've diagnosed that they have evaporative dry eye, Meibomian gland dysfunction or aqueous deficiency, you want to monitor whether your treatments are successful. And so if you check the patient's osmolarity before you start treatment during diagnosis, you can actually monitor 2 or 3 months later that your treatment is becoming successful and the osmolarity readings are falling. You can see the inflammatory cycle of dryness, and so the tear hyperosmolarity occurs with the inflammation. Now, if a patient has an osmolarity reading of between 300 and 307, that's normal. But the magic number to remember with tear osmolarity is 308, because that's when they start to be marginally dry-eyed. So when you're measuring osmolarity, a patient with an osmolarity reading of up to 307 is wet or normal. 308 to about 320 is mild dry eye. 320 to up to 340 is moderate dry eye, and over 340 is severe dry eye. Now this is very useful when you are trying to monitor whether your treatment is working, because you should get a reading which goes down after successful treatment of whatever type of dry eye condition you diagnose and treat. If the patient has either evaporative dry eye or Meibomian gland dysfunction or aqueous dysfunction, you will find that the osmolarity is raised. So you just remove the appliance from the machine and you have to click it into position, not touching the gold, and then you remove the covering, and then I'm going to measure the left eye as well. So I need you to blink for me, please, and I want you to look up and to the right. I'm just going to rest this onto your cheek. So I'm just going to pop this back and we'll see what reading this one is for the left eye. It's 318. So again, you know, this eye isn't quite as dry as the other one, but there isn't a lot of variation between the two really. They both have moderately dry eye. With tear film osmolarity, you will find that if they have a higher reading and they do have dry eye, then the results will be more erratic. And this is the same when you have a patient with glaucoma. at the very early stages where their field loss comes and goes. And so it's quite noticeable with a normal wet-eyed patient, the osmolarity readings are very accurate, they don't vary. But with a dry-eyed patient, you will get a variation in those readings. The sensitivity and specificity of the osmolarity readings is very good though. And at the end of the lecture are all the references. I suggest that you have a look at the work of Professor Alan Tomlinson on osmolarity if you're interested in this subject, and read the references at the end. When you're measuring osmolarity of contact lens patients, you actually get a slightly higher reading because the contact lens disrupts the tear film and breaks it up, and so you get a slightly higher osmolarity reading in contact lens wearers as opposed to non-contact lens wearers. The machine that we use to measure osmolarity is quite an inexpensive machine to buy, and osmolarity is a very interesting subject, and it does help in the armoury of assessing dry eye. Unfortunately, the chips that we use to assess a patient are gold chips, and the price of gold has escalated. So it's a fairly expensive method of measuring with dry-eyed patients. And although osmolarity is a very useful tool in everyday practice, it would mean the eye examination for dryness would be quite an expensive process. If you find that your patient is giving you a lot of dry-eyed symptoms, they've got burning, they've got stinging, they're very unhappy, and yet you can't see very much damage, it's very possible that on the lower eyelid you will see this telltale Meibomian foam. This is the Meibomian foam acting like a surfactant. And when this happens, it's very uncomfortable for the patient, and they give you a lot of discomfort symptoms, and yet you can't see very much wrong with them. The best way to try and treat this is with a course of doxycycline, about 50 milligrams for 3 months at least, if not 6 months. The snag with that is the patient will find it's much better, and then they'll rebound when they finish the treatment. You probably need them to make sure by then that they've done their Meibomian gland treatment so that the surface doesn't break up as quickly. This patient has mucin deficiency. The best treatment for mucin deficiency is to prescribe something called acetylcysteine. There is actually a drop that I tend to use which is preservative free, and that's supposed to help reduce the apoptosis of the goblet cells, and I quite like that particular treatment. This is something called pinguecula, which you see with incomplete eyelid closure. Now this is more common on patients who used to wear the old hard or gas permeable contact lenses, but in fact you can see it on dry-eyed patients when they get incomplete eyelid closure. That means they've been dry for many years. That's just a fat deposit, it's not harmful, the body's just laid it down to prevent damage actually. We tend to fit a lot of silicone hydrogel contact lenses, and the problem with silicone hydrogel contact lenses to a certain extent is that they have lipid buildup, unlike the old soft lenses which have protein buildup. And if you use an eye drop which has a lipid base to it, then it does make the contact lenses very greasy. Now, initially, they used to use surface treatments on the silicone hydrogel contact lenses to make them wet. But unfortunately, in making the surface wet, it also attracts the lipid, and you tend to get lipid deposition. Some of the more up-to-date silicone hydrogel materials contain internal wetting agents, things like polyvinyl pyrrolidone. Now, the internal wetting agents leach out of the lens and make the surface of the lens very slippery, which is called lubricity, and it lowers the coefficient of the surface. And so when you blink, your eyelid slides and glides and it's very comfortable, but it also helps to make the surface wet, and it helps to reduce the amount of deposition of lipid on the surface. So if you have a dry-eyed patient, If you use a lens with an internal wetting agent, then that makes them a lot more comfortable, and they can wear their contact lenses longer before they feel that dryness sensation. There are also quite a lot of different solutions in the manufacturer's blister packs which actually help the lens to wet. And so different manufacturers have invented different types of wetting agents that the contact lenses are soaked in, so that the lens is more comfortable on application, and they also mean that the patient stays wetter for longer and they don't get their dry-eyed symptoms for a few more extra hours. In the USA, one study has shown that with contact lens dropout, 50% of patients, they think it's due to Meibomian gland dysfunction. And if you need any help with your dry-eyed patients, this is my email address. Thank you for listening and watching.